Well, hi, everyone, and welcome to Managing Resistance. This is a community dementia education program of Alzheimer's San Diego. My name is Amy, and I'm the Director of Education with Alzheimer's San Diego. And I'm very pleased today to be joined by my colleague here in the education program, Jean Alton.
Hi, everybody.
Jean and I will be co-presenting the program today. And helping out today, we're very happy to have the assistance of Kristen, who is a social worker on our clinical services team here at Alzheimer's San Diego. Hi, Kristen.
Hey, everyone.
So here is our agenda for today. I'm going to start by talking in brief about the causes of resistance, why we see so many people with dementia become resistant to our attempts to be helpful, our attempts to have conversation. People can resist in a number of ways and resist for a number of reasons. So we'll talk briefly about what's going on internally in the brain and why this is happening, and then get to some techniques for effective communication with somebody who is being resistant. And we're going to talk at some length about providing care, providing practical hands-on help to somebody who is resisting your attempts to be helpful. And then, of course, we will make sure that you know where to go for additional information and resources for more support on this issue and many others as well. So let's talk about the causes of resistance in people who are living with dementia. And I want to say I'm not going to spend a lot of time talking today about Alzheimer's disease and other forms of dementia, the pathology, the diseases themselves. But I want to make sure you know we have other programs available in our webinar library. There is the Dementia 101 program in particular that provides a good overview of these various diseases that cause the symptoms of dementia. We also have a lot of great information on our website. If you click on the About Dementia tab, you'll find a host of resources there. So I'm going to be brief and keep us focused on resistance specifically here today, but want to make sure you know where to go for more information if you need it. So a metaphor that I like to use for caring for somebody who is living with dementia is a comparison to these ocean waves that I hope you can see on the screen. So imagine yourself there for a moment, kind of wading in, getting up maybe past your knees, up toward your hips, right? Where the water is cool and it's refreshing and it's a beautiful place. You hear the sounds, it's relaxing. There can be a lot of joy in this. But the further you go in, right, the less steady on your feet you become, right? It's much easier to get rocked back and forth by the strength of those waves. And, you know, frankly, if anyone who's spent enough time on the coast of the edge of the Pacific here in San Diego or elsewhere, you know, these waves can be downright dangerous, right? You look away for a moment and something's coming at you. You resist too much, right? You try to be too strong. You try to be too stiff, too rigid in the face of a big wave that's coming. And what's going to happen? It's gonna knock you over, right? So there can be a lot of good. There can be a lot of happiness, a lot of joy, a lot that's really pleasant about a continued relationship with somebody through the progression of the symptoms of dementia. It isn't all negative, but it is something that we necessarily have to sort of keep on our toes about it, right? And be ready for those big waves when they hit us. So why is it so challenging, right? The needs of the person who's living with dementia are constantly changing, kind of like those waves. It's always churning. It's never the same wave twice. You sort of figure out a strategy that works for managing a new symptom or a changed symptom or a changed ability in the person. You adapt, you figure out something that works, and then tomorrow or the next week or the next month, it doesn't work anymore, right? So their needs are always changing. It can be depending upon the person and their needs and your relationship to them and whether or not you're actually providing it. Being a caregiver to somebody living with dementia can be a very physically demanding role as well. It is a risky endeavor for a lot of people. If you're trying to care for somebody who's bigger and stronger than you, especially, but even if the person is not bigger or stronger than you, this is a full-grown adult with a full set of, wishes, and they know what they want, they know what they don't want. And if you're interfering, you're getting in the way. Right? It can be very difficult to physically try to coax somebody into accepting your help, or getting outside for a walk and some fresh air and some exercise, whatever it might be. This is also a condition. The diseases that cause dementia frequently disrupt people's sleep. That's very common, that there's more napping during the day, more wakefulness at night. And so you, as a care partner to that person, even if you don't live together or if you don't share a room, you are likely to be experiencing sleep disruption yourself. So you've got the emotional challenge of providing this care, you've got the physical challenge, and you're trying to do all that on very little sleep. Does that sound familiar to anyone? It can also be a very isolating circumstance if you don't know people in your life, if you don't have a support system of people who understand the specific challenges that dementia presents. It can feel very isolating, not only to you as a care partner, but the person that you're caring for. Even if they aren't alone very often, because of changes going on with them, they may be having a harder time relating to you, relating to other people, getting as much out of activities as they used to. So they begin to feel socially isolated, and you, as well as a care partner, may be feeling isolated. And then, of course, there's the big category that we just refer to. We lump it all together as behavior, right? People doing things that are out of character for them, saying things, acting in certain ways that are uncharacteristic for them. And one of the most challenging behaviors that care partners tell us that they face, the reason we developed this program, is resistance, right? The refusal to say yes to things, to agree to get outside for a walk, to eat a meal that has been lovingly prepared, to accept your help with toileting or bathing or taking medications, right? All of these different attempts to help. One of the most challenging behaviors that we see. So in those challenging moments, in those moments of frustration, I want to encourage you to try to remember that this is the result of pathology. When it comes to progressive forms of dementia, unlike other illnesses, often the person doesn't really look all that different. And much of the time, they may act a lot like their old selves. It can be very easy to forget day to day, moment to moment, that this person is living with a progressive neurodegenerative condition that is causing brain cells to die, that is causing brain tissue to wither. This image can be hard to see. It's just a graphic depiction of what happens in the Alzheimer's type of dementia. But I just like to sort of remind care partners, if we were able to see this happening, right, it might be easier for us in those moments to be a little bit more capable of the patience and the forgiveness and the understanding that the person needs from us in those moments. So what exactly is going on? What causes resistance? So when there is damage in the temporal regions of the brain, this is the part of the brain where Alzheimer's disease, that particular form of dementia, tends to start. So this is the part of the brain where the pathology begins for most people with most types of dementia. We'll see significant short-term memory loss, changes to a person's language. So, a person who has taken a medication for a very long time, for example, and begins to refuse that medication. I don't need this. Why do I take this? I don't remember anybody prescribing this, right? That's a particular type of resistance that we might see in somebody who's got damage in that region of their brain. When there's damage up in the parietal lobes of the brain, what we see is changes in the ability to make sense of sensory information. So when there's damage in the parietal lobe, one isn't necessarily hearing, smelling, tasting, feeling anything differently, but your brain is interpreting all of that information differently, right? Our ears hear the sound, but your brain tells you what you have heard, right? This is also a part of our brain that's very involved in a lot of our manual dexterity, our ability to use our fingers, our digits. So this might present itself as, somebody who's got damage in their parietal lobe. Something you might see is on a hot day, somebody who insists on wearing layers and layers of warm clothing inappropriately. It's not that they don't get hot or feel the warmth. It's that their brain isn't telling them this is too hot, right? That all of this layering is going to be difficult, or is going to make you hot and uncomfortable and maybe overheat. Or once all that clothing is on, right? Difficulty with dexterity could make it harder to get it off, for example. So no, I'm fine, right? We'll just leave this on for now. When there's damage in the occipital lobes toward the back of the brain, what we'll see is a significant narrowing of the person's field of vision, which causes a loss of peripheral vision, but also difficulty with depth perception, the ability to interpret contrast, to tell how far away things are. We'll see a lot of difficulty with balance and more falling in people who have damage in this region of their brain. So if a type of resistance that you see is somebody who refuses to take a bath, for example, there could be many reasons that they might be resisting taking a shower or a bath. But if they've always really enjoyed those things and now they don't like it as much, right? Might it be that the sensation of water coming down from on high, if their brain is confusing what that sensory information means, this may not be a pleasurable activity for them. It may feel uncomfortable. It may make them frightened. They may have worries about their balance and their falling because their peripheral field of vision is different. Right? So all of those things can factor into why somebody is refusing to participate in a task that they used to otherwise enjoy, or at least be willing to do on a regular basis. And then the frontal lobes, this is a big, complex region in the front of our brain that's very involved in our communication, our understanding of each other, our ability to have empathy for other people, our ability to use judgment and reason to problem solve, to think things through. And this is also the part of our brain that regulates our emotions. So a lot of the features of our personality, the way we act, the things we say and do is kind of regulated in this part of the brain. So when there's damage in this region, what we might see is somebody who just frankly says no to everything, because the ability to say yes requires a lot of executive function, right? To think through, if I say yes to this, then what's the next step that's going to happen and what's going to happen after that? So a lot of just saying no, a lot of difficulty with empathy, not knowing why you are being so difficult, right? If I don't have good insight into what's changing with me as a person who's living with dementia, I certainly don't have insight into why you are always in my business, right? Why are you always trying to help me? Why can't I make my own lunch anymore? Why is somebody always coming over? And why is somebody always in the bathroom with me, right? So when somebody is experiencing changes in those parts of their brain, we're going to see a lot of difficulty with empathy in particular. So all of this leads to what we, sometimes refer to as behavioral symptoms, behavioral changes. They're not always negative, but of course, that's what we're here to talk about is resistance. So we're focusing today on the negative ones, right? Difficulty with decision-making, judgment, being more agitated, perhaps becoming combative, having a hard time starting and stopping, initiation and termination of tasks once you get going, right? Being unable to sort of stop with something, or not knowing, if I say, yes, let's go for a walk, being able to do the next thing I need to do. I need to locate my shoes, right? Just being able to initiate a task like that can be difficult. Confabulation, this is a fancy word for something that all of our brains do, It's an essential cognitive function, and it basically refers to kind of making stuff up, right? When we don't have the full picture, and we usually don't have complete pictures of any particular scenario. Our brain has to do lots of filling in. You've all seen those games and puzzles and memes online where there's a sentence that's missing half the words, or words that are missing half their letters. You can still read it, right? You can still understand what's going on. That's confabulation at work, right? Your brain doesn't see it, but it knows what belongs there. Well, this happens in the brains of people living with dementia too. And in fact, it's sort of an overactive activity, if you will, because there's more gaps in their knowledge, in their memory, in their understanding of what's going on. So their brain is doing a lot of making things up about what's going on around them. Unfortunately, that leads to suspicious behavior, feelings of paranoia, even toward very deeply loved, long trusted people. Though suspicion and paranoia is not a reflection of the true nature of your relationship or how they've always felt about you. I think a lot of people internalize that, right? When my mother starts refusing medication because she thinks I'm trying to poison her, my gosh, what does that say about how she really feels about me? Right? Nothing. What it says is that her brain is confabulating, right? There's some gaps in her knowledge and her information. The neurons are doing their thing, right? And filling in those gaps. And unfortunately, it's created a story for her that results in suspicious feelings toward you. So limited insight into care needs. This is one of the most important changes, results of all these brain changes that we need to focus on in all of our roles as caregivers and care partners to people who are living with dementia. Most people, the majority of people with dementia, have a very difficult time seeing their own disability. This is a medical condition. There's a fancy word for it called Anasagnosia. And it just refers to not having insight into one's own decline, changes in a person's abilities. It happens in many types of illnesses, and it happens very frequently in dementia. So we see people who just don't know that they need help. Does this sound like the person that you care for now or at some point in the journey? But I'm fine. I don't know what everybody is worrying about. Right? We often interpret that as a person being in the state of denial or being manipulative or lying or trying to cover up, when in fact is often that they just don't have any insight into what's changed with them. And therefore, right, I'm resistant to your attempts to be helpful to me. So I'd like to, before we move on to the important topic of, communicating in the face of resistance in somebody who's living with dementia, pause and see if there are any questions that have come in.
We haven't had too many questions so far, but one person was wanting to know if it is common for someone living with dementia to be cold all the time and to fall frequently.
Yes, both of those are very common. The falling, I mentioned when there's changes in the field of vision that will frequently produce difficulty with balance and gait. The center of gravity is just sort of off, and often the person has to be sort of looking down and changing their body position. They're having a hard time interpreting how tall is this curb, how high do I need to lift my foot in order to step over it, for example. So that's a pretty common one, and it's directly related to the brain changes in dementia. Being cold all the time isn't necessarily a symptom of dementia, although Jean, feel free to chime in with any other information here, but this is actually just a very common thing that happens to most of us as we age. The fat deposits on our body when we're younger, fat tends to be more evenly distributed throughout our body. And as we age, if anybody has noticed, it moves around, right? And it doesn't necessarily keep us overall as warm as we used to be. And a person with dementia may have a harder time kind of regulating that, right? So we do see all the time people who are fighting all day long over the thermostat, right? The person with dementia is constantly upping it when they're not looking. because they are uncomfortably cold a lot. Anything
And
you
I
add
just
to
would
that,
add
Jean?
that, I think what is important for us to do is connect these type of sensory changes that are going on in people to resistance, in that if my visual, field is fuzzy a lot of the time, that may be my fear that's causing me to not want to go with you, to go to the bathroom or whatever it might be. So resistance isn't always a resistance. Sometimes it's something else. It might be fear. And being cold, maybe that's why I don't want to have you help me get undressed or have a
Yes.
bath, because I am cold. So again, resistance, how it manifests as a behavior doesn't mean that that's what's going on in their brain and that that's the root of that expression. It can be something else that they are feeling and experiencing that is causing them to do what is very normal as human beings. If I'm
Yes.
cold, don't try and take my sweater off me.
Right. Absolutely. And you think about, all of us, particularly in the colder months of the year, when it's time for the bath or the shower, you have to get undressed. And that is an unpleasant moment, but you can think a few steps ahead and say to yourself, this is going to be like 5 seconds. And then I'm going to be in that nice warm water and I'm going to be okay. Right. If a person has difficulty with sequencing and abstract thinking, as Jean is saying, they're in the moment right now and they're thinking about, I don't want to be cold.
Mm-hmm.
Yeah, great point.
So I think I'm stepping in now. Is that right, Amy?
Yes, let me give you the remote here.
All right, let's see if we can make this thing work today. Come on. Come on. I'm now talking to my mouse. There. Did I actually do that?
Mm-hmm.
Wow. Thank you, mouse. So we are going to talk about techniques for effective communication, and there are specific techniques, and it requires some diligence on your parts as care partners and some time to acquire these skills and make regular use of them. And then that means practice, of course, too. So, but it's worth the investment, folks. You can go a long ways here by getting a few of these tools under your belt. So, well, really, what is resistance? Well, it's all sorts of different things. And so what I wanted to do, what I was thinking about as Amy was talking, was thinking about, all right, apathy is a form of resistance, and apathy can take many different manifest itself in many different ways. Everything from somebody just sitting on the couch and refusing to get up when you ask them to, or out of bed, or not answering you when you ask a question, not making a decision between I'd like to eat this or I'd like to eat that, just general disinterest in things. And apathy is something that we can see throughout our lives. And so what I was thinking about is, how would we describe apathy in a person with a healthy brain? And sometimes I think we might describe apathy in a person with a healthy brain as procrastination. We'd say, well, I asked my husband to, take the garbage out and he didn't do it. And he's procrastinating again. And in fact, it might be apathy. It's kind of a form of resistance. But again, for our folks living with dementia, is they're missing that ability to kind of think through things, and also to have that initiative, that self-starter button to get things going. So apathy gets to be a default mode, and we tend to interpret it as resistance. When we have people arguing with us, well, in people with healthy brains, we kind of talk about that as they're disagreeing with us and being contrary. And for people living with dementia, that's not necessarily the case, and it oftentimes isn't, because disagreeing and being contrary does require higher level executive function. And so I think when our people living with dementia are arguing with us, we need to look a little bit behind the content and more at the feelings that they are expressing. And again, it might be something like, I'm arguing with you about taking off my sweater because in fact I'm cold. We see people refusing assistance, and in people with healthy brains, we may describe that as being independent. And so there's there can be a positive spin on refusing assistance when you have a healthy brain. They're independent, they want to do it all themselves, a self-starter and a self-learner, and just really determined. And yet I don't think we tend to use those terms or look at it in that positive manner in our people with dementia. And perhaps we should, because I think it runs through most of us as human beings. I think it runs deep, our desire to be independent and autonomous, even in spite of the damage going on to the brain. And so sometimes I think we have to honor a little bit of refusing assistance, and then find some ways to work around that while honoring that spirit of independence and autonomy. Combativeness is something we may see in our folks with dementia. Combativeness being, kind of escalated arguing, also maybe getting physical as well too. And for a person with a healthy brain, we might describe them as being kind of out of control or aggressive, or they can't control their emotions. And once again, we may tend to transfer those types of perceptions to our people with dementia. And in fact, their combativeness, in my professional experience, is almost always born out of emotions of fear, anxiety, a real response to a dangerous situation, and they're protecting themselves. And so again, we need to kind of look beyond the reaction that we're getting as to what is the root of it, what is the emotion that they're feeling. And lastly, we say, I'm trying to get my mouse to work again here. Come on. Saying no is resistance, and for sure saying no is resistance. And we may again look at that as people being maybe difficult because they're not agreeing with us. But saying no is really just saying no. And that can be no for the moment. That's not necessarily no forever. And if they're saying no, they are saying something important to us, and we need to listen to that and figure out the intricacies behind it, because we can't sit down and have perhaps that more detailed and higher executive function conversation that we may be able to have with someone saying no to us who has a healthy brain. So, there we go. So no versus yes. Well, let's just think about it for a minute. We've got this little organ in our brain, and you'll see that's way down there, and you see the arrow pointing to it. It's just this little nugget-sized organ in our brain. It's called the amygdala. And it's what sometimes people refer to as our reptile brain or our prehistoric brain. This is the part of the brain that keeps us safe from harm. It's the part of the brain that is not usually damaged in our folks with dementia. And so this is why we see people operating from a place of fear and anxiety and defensiveness about what is going on around them. think about when we say yes, we're opening ourselves up to whatever might happen. We're opening ourselves up to something. And when we say no, we are keeping ourselves safe. And so that's what our folks with dementia are doing, is keeping themselves safe. So what is happening in their brains? Well, they are processing the environment that is happening to them, obviously feeling the emotions that it's evoking within them and following that. So if the amygdala is firing and saying, danger, danger, then you're going to get any one of those forms of resistance. And so, in the healthy brain, we may have that signal of danger, danger, fight, flight, or fright. But we're usually able to kind of tamp it down, usually, and kind of figure things out in a more logical and measured fashion. And that opportunity does not always appear for our folks with dementia, and in fact, often is not something that they are able to do. So that means, when you are dealing with some type of resistance, we need to look at some different ways of responding. So that's why we asked you to look at what is happening in your brain when you are being met with resistance. So when resistance is being given to us, remember that our amygdala then is firing up too. And, we've all been in that position, right? I was just this past weekend with my husband over a couple of things where I was ready to, duke it out, as I say, which is not literally being combative, duking it out, but I was ready for an argument. But thankfully, my amygdala was firing big time. Thankfully, the executive function of my brain was firing enough to tell me, just calm down, just leave it, just leave it, just leave it. And that was enough time to give these smarter and slower parts of my brain time to catch up and come up with some better responses and reactions to what was going on. And, really, that's what we need to do with our people living with dementia. So we're not in this reactive versus reactive situation, which is almost always to the benefit of no one. And so here we go. Take a deep breath, folks. Once again, take a deep breath and really do it. Breathing in through the mouth and out, in through the nose and out through the mouth. And have a stretch while you do it. Deep breath. Why do we do the deep breath? That is giving our brains a little bit of time here to reset, which we absolutely need to do. So we do want to be responding versus reacting. So when we think back to those waves that are coming in, we're standing on one of the beaches somewhere, Torrey Pines or La Jolla Shores or, wherever it may be. And those waves are coming in and they're big, strong waves. We can stand firm and hope that we can hold our own when the wave crashes into us, or we can dive in and dive under and let the wave just wash over top of us and we come out underneath and on the other side. And if you've done this, I've done it, I know Amy has too, I'm sure many of us have. We know that the better of the two options is to dive in, and leaves us more in control of the situation and less likely to be knocked over by the wave and left sputtering and gulping down copious amounts of ocean water and on our butts on the sand with Just feeling kind of embarrassed and silly that all this stuff has happened here in front of people. So what does this mean? Well, we're talking about reacting versus responding. And so reacting is when we start correcting people. Examples. Don't you remember? I told you we have an appointment this morning with the doctor. No, you didn't tell me. Yes, I did. I called you this morning and I told you I put it on the calendar. I've been talking about it all week. We're correcting them. Or they are saying maybe that in the middle of the night, they're saying it's time to get up and go to work. No, it's not. It's the middle of the night and you don't work anymore. You retired 20 years ago. What? This is ridiculous. Get back to bed. We're correcting them. We're confronting them as well, too. You're talking nonsense. That's simply not true. We're butting our heads against them and telling them that whatever their thought process is or their belief is incorrect. It's wrong. We're arguing with them. Again, just this back and forth, head to head, and trying to get them to do what it is we think they should be doing or we want them to be doing. Versus responding, which is validating. Oh, you didn't, we've got a doctor's appointment this morning at 9. Oh, you didn't tell me that. I didn't? Oh my gosh, I'm so sorry about that. That's my fault. I meant to tell you. I thought I put it on the calendar, but I guess I didn't. So I'm very sorry. I'm sorry I've upset you with this last minute news. I'll make sure that doesn't happen again. Shall we go to the doctor's anyways because we're up and dressed and ready to go? Reassuring them. It's the middle of the night, they're up. I have to get up, it's daytime, it's time to go to work. It's not quite time yet. We've got a little bit more time before work. I know your work is really important to you, Dad. You've always just been such a reliable worker, never missed a day. So I'll reset the alarm for us to make sure that you are up and at work on time. But come back and let's just rest for another hour or so. Redirecting, just as I did. Giving them some reassurance and saying, then I'll set the alarm, come on back to bed for a little while and we'll rest for another hour. And or redirecting to, I've got some great pictures from, the kids, the birthday party they were at the other day. Let's go take a look at those for a few minutes here before it's time for you to go to work. So all sorts of different things that we can do. The point is we're responding rather than reacting. So communication techniques. It's best to be using a calm and reassuring tone. And if you don't feel like that's something you can achieve in the moment, honestly, go give yourself a timeout, take 5 in the bathroom, do some of that deep breathing, and then go back and start over with that calm and reassuring tone. Keep your directions and any questions you ask short and clear. Don't go into long-winded explanations or long-winded question sessions. Keep it concise. Allow plenty of time, not only for your person to process the information that you have just given to them, but also for them to respond back to you. More time than what we normally would allow in conversations with people with healthy brains. Repeat as needed for understanding. And don't embellish your repetition with further explanation and language. Again, keep it concise. Validate and agree. So important. There's, none of us like having people telling us we're wrong and arguing with us. Nobody responds very well to that. With healthy brains. And now we're talking about people with brains that are damaged by dementia. Please be generous with giving your validation and agreement to them, and also forgive and apologize. so much power in the words of "I'm sorry." Even when it's not your fault, but you take the blame for it. Great power in that, and it's a great, I guess what I'm all sorts of different ways I could say it, but for right now, what I'm thinking is it's a great way to unite the team and get the two of you, or if there's more in the family unit, working as a team rather than working together as a team rather than working against one another. Very important. So, and this one is a good one because it's saying that, you know, really one of the best pieces of advice and or a communication technique to give to you folks is really what we need to do, which seems funny with when we're talking communication and managing resistance. But the fact of it is we need to talk less and listen more. So remember this little funny face with the finger over the lips, talk less and listen more. So with that, hold on, there we go. Amy, are you coming back in here?
I'm trying. Our cursors are fighting. Okay.
Our cursors are we're sword fighting.
There we go. We get into some Zoom fencing every now and then. Thank you, Jean. I wanted to just do a quick kind of poll here and see if folks were paying attention in that last segment. So I'm going to go ahead and launch a poll. You should see a question having popped up on the topic of reacting versus responding. The following is a way of responding to what a person with dementia is expressing rather than reacting to the words that they said. So check all of them that apply. You should be able to select 1, 2, 3, or 4 of these answers. Is it considered responding when you correct someone to show them when something is wrong and help them make it right? Is it considered responding when you're reassuring somebody, reducing their worry or their uncertainty about something? Like Jean's good example of, I'll make sure that doesn't happen again. You know, that's a nice example of that. Is it a way of responding when someone is, when you validate someone, affirm that they're correct, their feelings are valid? And is it a form of responding when you confront the person and challenge them, again, helping them to sort of set the record straight, right? What would you say? Go ahead and vote. We've had votes are still coming in, and I'll show you the results here, and then we'll talk about it. Okay. Give it 5 more seconds as your final chance to get in your answers.
You don't get your final grade unless you do the
This is an anonymous poll, by the way. We don't know who answered and who didn't, or who got it right, but go ahead and show you the results. You did a great job. You did a great job overall.
Yes. Yay!
100% of you who responded recognize that reassuring the person, reducing their worry is a way of responding and not reacting to the person. Validating is the other answer that we were looking for. Great. Thank you. Hopefully I have closed that poll out. If I haven't, if it's still in your view, just click the little X in the upper right-hand corner and it will go away. Thanks for participating. And
well, and
nice
that
work.
helps validate that you know, you were listening to me.
That's
so thank
right.
you.
That's right.
All right. So Amy, I think you're going to talk to us a little bit now, right?
You are correct. Okay. I'm going to talk now about some sort of practical caregiving applications for much of what both Jean and I have been talking about so far. I see a really great question in the Q&A here that I want to talk about here for a moment. My mother I'm going to read it out loud first. My mother absolutely refuses to use a walker. She has fallen twice in the past month. She will have home health PT soon, PT being physical therapy. Do you think PT is a good idea? Do you have any other ideas? And when it comes to caring for somebody who's living with a progressive condition like dementia, we really have to rethink our way of thinking. We have to reframe our way of thinking. There we go. We are used to, when we're caring for somebody who is recovering from an illness, an injury, right? They had the flu, pneumonia, they broke a bone, and they're rehabilitating. This is usually the context in which we are caring for people. We expect for those conditions to get better, right? When it comes to a progressive form of dementia, Alzheimer's disease, a vascular cognitive impairment, a Lewy body dementia, unfortunately, we have to plan for, expect, anticipate a progressive loss of function. The person is declining over time, losing skills and losing abilities. Our goal when we're caring for people who are living with dementia is to help them be as autonomous as possible, but we're not usually striving for the goal of independence. We're just being realistic, right? We're being flexible about our expectations of what's possible for them right now, but also, again, in thinking ahead in the future. So we tend to kind of come at caregiving from a rehabilitative framework that doesn't really apply. What we have to do instead is what's called habilitation, where you look at what's the person capable of right now, meet them where they are, and work with what you've got, right? When Jean was talking about seeing resistance in a more positive way, when somebody says no to you, that's actually a reflection of something they're still able to do. That's kind of what I'm getting at here. So the question about physical therapy really brings this issue to light for me. Physical therapy, getting somebody to learn how to use a walker, for example, this is a rehabilitative strategy, right? They've lost some skill and some ability, and we're trying to teach them some new thing, remembering to use a walker and knowing physically how to do it. Not something that's going to be possible for most people living with dementia at a certain point in the disease, mid-stage or later. It's just not something that we can reasonably expect for people to do. But is physical therapy itself as an activity still valuable? Absolutely, because people still have muscles and balance, and let's keep the parts of their brain that are still healthy, the parts of their body, they've still got muscles and a cardiovascular system. We want to keep strong and flexible and help them maintain as much physical balance as possible. Absolutely, physical therapy is a good idea. We just want to be thoughtful about, or careful about, our expectations regarding the goals of it. That makes sense? So when we're providing care, we want to come at it from a habilitative standpoint. We want to think about not jumping in as, again, I think it's just kind of our instinct, our impulse, especially people who have raised children or who are supporting grandchildren who are growing and developing new skills. We want to push people to do as much as they can. When they're not doing it right, they're not doing it correctly, we want to jump in and do it for them, right? And when it comes to providing personal care, our impulse often is to just step in and do things to people in the name of their resistance is too hard to overcome. I'm just going to get this done, right? It's time to brush your teeth. So here's the toothbrush, right? Let's just get it right in the mouth, right? So I'm asking you to just sort of think differently about your approach to people and learn how to do things with people instead of doing them to them or for them. So a good place to start is by creating what we refer to as a dementia-friendly environment, right? Setting up your room, your situation, the stage, the table where you're going to be sitting, whatever the task at hand might be. Set up the area so that you are reducing some of those barriers and obstacles to effective communication and getting them on board with what it is that you're trying to get them to do. So eliminating clutter. If you want somebody to get their shoes on in order to go for a walk, right? Point them toward the area where the shoes are instead of just like asking them to open up the closet door and see all the different things that they might put on, right? Reducing the amount of choices and options that they have in this case is a really good thing. So decluttering the area, if you're getting ready to engage in personal care, for example, you want somebody to focus with you on brushing their teeth, don't have all the other grooming supplies out at the same time. Have what you need. If you're getting ready for a bath or a shower, have all the stuff you can think you might need right there within arm's reach. So you don't go to all the work of getting the person undressed, getting them in, you do all that work to get them in there, and then, I don't have any towels or washcloths, and you have to leave to go get those things, right? Take the time up front to prepare your environment. Minimize those distractions. Again, that can be clutter, it can be sounds, it can be visual distraction, mirrors in bathrooms, mirrors in other rooms. A lot of dining rooms and living rooms have mirrors too. Mirrors can be very distracting and confusing to a person who's living with dementia, so you may want to consider removing them or covering them temporarily or permanently in order to eliminate that distraction. Have a good, comfortable place for them to sit, or whatever posture they need to be in for this task, and have a place for yourself as the care partner as well. And that's kind of the piece of this a lot of us tend to forget. Oh, right, how was I supposed to fit into this situation? You both need comfortable, accessible seating that you can get in and out of easily. Good lighting seems obvious, but in fact, as those senses are changing, the changes in the parietal lobe that I was talking about at the beginning, it can be very difficult for people with dementia to try to be doing things, to participate in activities in low light. They may need much more light than they needed before. And then to that great question about body temperature, yes, people with dementia frequently are colder than they used to be. They feel colder, they feel less comfortable in environments that aren't especially warm. So warm up the bathroom. If you're going to be helping somebody get dressed, make sure the bedroom is warm, or warm up the bathroom in advance of the shower, for example. So we'll run through a couple quick tips in a few specific areas of caregiving. I want to just mention that we do have a great library of tip sheets on a whole variety of different topics. So any of these issues you want to dig in and get some more detailed information or ideas, you can reach out. Kristen, can I ask maybe in the chat if you could put out the request for follow-up services? You can reach out and a member of our clinical services team can send you some more information, or you can request that they give you a call. They can talk you through your specific situation and give you some ideas for your particular setup, and of course for the particular person that you care for. So, but when it comes to bathing and showering, I know this is a huge issue for a lot of care partners. A few ideas that we hope will help minimize some of the resistance that we see. Again, getting those supplies that you need in advance, having everything that you're going to need within arm's reach. Use lots of towels and washcloths. They help with warmth. They help with privacy. Somebody who is not comfortable getting undressed in front of you, and keep in mind, even if this is your significant other, you've been undressed in front of each other for day in and day out for decades, that doesn't mean that they necessarily feel comfortable being bathed by you, right? Getting undressed and being vulnerable in that particular way. So using towels that are going to get soaked, right? Letting them get in the shower in their undergarments, right? So that helps them feel a little more protected, a little more privacy. And then this is a tip that came to me from Teepa Snow, a really terrific dementia educator and occupational therapist, who noted that most of us, when we are wearing wet clothes, our impulse is to get them off. It feels uncomfortable. So if you let the person get into the shower partially dressed, right? If that's what gets them in there because they feel more comfortable, great. You get them in there, you get them wet, and then you're probably going to be a lot more successful at talking them into getting them off. right? If you do it that way. So I did see that question about somebody who's really struggling to get their husband to change his underwear. This may be and the refusal to change clothes is very common in people with dementia. This might be a strategy, right? Getting into the shower, the bath, jumping in a hot tub, right? Whatever your situation might be, getting them wet in that undergarment and then suggesting that they take it off. That might be a helpful creative strategy there. Preparing the room with, to set it up in that dementia friendly environment, minimizing noise, but maybe using music if it's relaxing and it helps. Getting it to a nice warm temperature, probably uncomfortably warm for you, unfortunately, is probably the right temperature for them most of the time. And again, bright lighting. Bathrooms tend to be too dark. So remember that they're having more difficulty with their visual spatial abilities, and brighter light is going to help with that. Being very simple and direct in your prompts, as Jean was talking about. Speaking slowly, speaking clearly is part of it, but also just being very directive in your speech. Your bath is ready. Instead of getting into the negotiation, right? Will you come take a bath, right? Try to do as little asking, as little negotiating as possible. It's time for X, right? Your bath is ready. Let's go, right? Or maybe even remembering that, not saying anything, going for a walk together and ending up in the nicely prepared, warm, scented, candle ready bathroom, right? And ending up there, that might be the right strategy. Getting dressed along the lines of getting undressed, which is a common challenge, getting people to change clothes. People there's a common pattern or behavior of wanting to wear the same thing over and over again, right? If that's the case, maybe consider, if it's possible for you, buying multiples of that thing, or things that look and feel a lot like that thing that they want to wear over and over again, and let them, right? But thoughtfully and quietly swap them out when you can. Keep getting dressed, keep the clothing and the clothing choices simple and comfortable. A tip I learned a long time ago that I've always really liked is to size up, one size up, so that it still fits and doesn't look baggy and unkempt if that's not how the person likes to dress. But one size up can be so much easier for you as a caregiver to help them navigate, and it can be a lot easier for people to get arms and legs in the right clothing holes, for example. So simple, comfortable clothing and footwear. Think about the complexity of most shoes can get very difficult when there's challenges with that manual dexterity that comes with these brain changes. Do what you can, again, thinking about helping the person do things for themselves as much as possible does not mean leaving them to it, right? You can do a lot of setup. You can set the situation up so that they feel in control. They feel autonomous. You, in fact, have provided a lot of help, but to them, it feels that they're really in control. So some examples of that might be laying the clothes out in exactly the opposite order in which they need to put them on, right? So the first thing, the underwear, the brassiere, that's all sitting on top of the pants, the shirts, the things that are going to come on later. If you're helping them get their shoes on, right, you might be doing the work of it, right, tying the shoe or moving the shoe on and off the foot, but ask them for their help, right? If they're sticking their hands in there, help them feel like they're helping you tie that shoe, or they're actually doing the tying of the shoe. Ask them to check it, right? Does this feel right? How did I do with your collar? How did I do with your button, right? Involve them, ask them for their input so that it feels like they're participating in this activity. Always respecting dignity, privacy, respecting choices to the extent that you can, limiting the amount of choices, right? There may be situations where they're just really overdressing and trying to wear far too many layers on a warm day, but maybe you can let them. And then, as the activity of the day goes on, you can sort of strip away layers to get them, to keep them physically comfortable, right? But as much as you can, let go of if things don't match, if things don't look perfect, if it's not totally suitable to the activity, right? If they're going to be reasonably comfortable, if it's fairly clean, right? Can we be flexible and adjust our expectations? Keeping your directions simple and providing lots of visual and physical cueing when you can, not just telling somebody to put on their shoes, but maybe putting yours on and showing them what you mean, right? Giving them a physical cue for what it is that you're asking them to do. Couple quick tips on mealtime and eating. And I want to say we do have a webinar specific to this topic in our webinar library. You can find that. It's called a Caregiver Skills Clinic on the subject of meals and eating. But a couple of quick tips here. Think about the person's, sort of regular schedule. Do what you can to kind of honor their routines and their rituals around food. Consider how you're timing, scheduling, and sort of pacing or coursing meals, trying to keep things as simple as possible, trying to schedule meals when there's not a bunch of other stuff going on in the house. Remembering that eating is a social activity for most people. Even a person who's lived alone most of their life has probably eaten lots of their meals in their life with other people. And so if you're scheduling the meal time such that you as the care partner are busy doing other things and you're just putting down a meal in front of them, but you're still running around taking care of things around the household, right? Remember that eating is a social activity, and that probably does not cue them. It doesn't signal to them, oh, it's mealtime. I'm supposed to be sitting here by myself eating this meal alone while he or she is running circles around me, getting things done, right? So slowing it all down, scheduling at a time that you can sit there, even if you're not going to be eating right now with them, can you sit with them, do something that looks and feels a little bit like eating along with them, right? So that it feels more like a social activity. It feels like something you're doing together instead of just sort of popping the meal down in front of them. Letting go of expectations, a common theme of the day here. Think about using or incorporating more finger foods into the diet because the use of utensils may become difficult for them as the disease is progressing. There are adaptive dinnerware, adaptive utensils that you can use. But remember, go back to that sort of idea of rehab and PT and occupational therapy. We're not trying to teach the person new skills, right? We're working with what they've got. So if using utensils is getting hard for someone, I would recommend before or rather than investing in adaptive utensils, just think about, are there ways we can change the makeup of this food, eat more finger foods, cut sandwiches into smaller pieces, right? A salad could be finger food if it doesn't have dressing on it too, right? Get creative with what exactly is finger food. And again, eating meals together or eating something together. If you're not eating a full meal at the same time that they're eating, can you put down a bowl of something, some grapes or something in front of yourself, so that you are providing the visual cue, the physical cueing, to show them it's time to eat, it's meal time. A couple quick tips on medication management, and I'm going to show you a short video on this topic. Medication management is a very common struggle for a lot of caregivers, and resisting taking medications is super common in people who are living with dementia. Swallowing disorders are common. It's something that happens as the brain is changing. Esophagus starts getting sort of mixed messages, so people start to cough and choke more on liquids as well as when they're eating or taking pills. So it becomes a little bit of a struggle physically, but on the topic of resistance, it generally just comes down to, I don't think I need this. I already took these. I don't feel like it. I'll take them later, right? It's back to the examples of apathy, those other types of resistance that Jean was talking about. So talk with the doctor, the pharmacist, both about, do we need to be taking all of these medications? See if anything can be eliminated. Talk about the timing, the scheduling of medications. If the person tends to be very alert, lucid, and more able to follow instructions, more compliant, frankly, at a certain time of the day. Let the doctor, the pharmacist know that, right? Here's what we're working with. Can we change the schedule, the dosing of these medications so that I can give the person that I'm caring for the bulk of their medications at this particular time of day when they tend to be better? Because the evening struggle is, they're refusing medication all the time. Let them know the circumstances that you're working with. Can we change the timing? Can we change the dosing? Can we change the format? Right? Is it something that can be crushed safely? Is it something that can be cut? It can be put into liquid or applesauce or yogurt or something but you don't want to just make those decisions on your own. You want to know that it is a pill that can be safely modified. Is it available in a liquid form, for example? So do talk with your pharmacist or your physician about any changes that you can make. And a really simple but important strategy is start with the most important ones, right? If she's supposed to take 4 medications every morning, but by the second or third one, she's starting to wind down and stop cooperating. Which ones are the most important ones in case we don't get number 3 or number 4 in? I'm going to show you this short video that was put together by our colleagues at the UCLA Dementia Caregiver Center, Alzheimer's and Dementia Care Program. There we go. They have this whole library of videos, and I'm going to share my screen with you here so I can show you. Bear with me. Jean, let me know if this is not working, but hopefully you are seeing it looks okay. Okay, great. You're seeing this library of videos, and this the URL, the address where you can find this library of videos is on the slide. So you don't have to write this down or remember it. But you can see over here, this library of caregiver training videos on a whole host of different topics. So I'm going to show you now I'm going to show you most of this brief video on the topic of refusing to take medications.
Grandma hates taking her medicine, even after I tell her what it's for. She asks 10 different times why she's taking it. What should I do? Time to take your medicine, Grandma.
I don't need to take medicine. Who said I have to take that medicine? For what?
What are you talking about, Grandma? You have high blood pressure and diabetes. Dr. Brown said if you don't take your medicine, you're going to get sick.
I don't need pills.
Why do we have to do this every day? Just take your pills. I give up.
Refusal to take medication is a common manifestation of dementia. It can be very frustrating for the family, particularly as this has to be done every day. Stay calm and be patient, keeping in mind that these medications help your loved one stay healthy.
Time to take your medicine, Grandma.
I don't need to take medicine. Who said I have to take medicine? For what?
Remember, Dr. Brown said you have to take medicine for your blood pressure and your diabetes. He even wrote a note. My patient, Aura Jackson, that's you, needs to take her blood pressure and diabetes medicine every day. So let's take your medicine for Dr. Brown.
Okay, I'll take it today, but maybe not tomorrow. Only because Dr. Brown said it's a good idea.
Okay. Oh, I have an idea. Let's take the dogs outside for a walk. It's a beautiful day.
Okay. So what I'd like to do, if you haven't found it already, please locate the chat function of in your Zoom control panel. Everyone see that there? Oops. There we go. And tell me what you saw in that video. What did you see? Stacy was the name of that granddaughter. What did you see that granddaughter do differently in the second video? What did you notice was different about what she did? I see a great answer right off the bat. She sat down. Yes.
She got face to face with her grandmother versus kind of hovering over top of her and giving instruction.
Yes. She was very calm. Yeah. Something I noticed about the first video, the difference between the first and second video is, in the first one, she comes in as Jean said, sort of ready to rumble, right? She knows she's in for a fight because grandma always resists. So she comes in kind of a confrontational stance. And in the second one, as you note here, she speaks softly, she stays calm. She used shorter sentences in the second video. Great observation. That is true. Yes. Anything else? Jean, is there anything you
I
recommend she try differently?
I really like that she provided, kind of the evidence of the note from the doctor.
Yeah.
And look, folks, you can create your own note from the doctor. You can make it look like it's on letterhead. And in fact, if you don't feel comfortable doing that, you actually can get a note from the doctor. It can be like on a prescription pad where the doctor writes that I want Mrs. what was her name? Mrs. So-and-so
Jackson, Cora.
to take her medications daily as I have prescribed.
Yes.
So, and then that way it's not on the daughter, that the daughter she's able to kind of deflect the blame and say, well, it's the doctor who wants you to do this. And in this instance, maybe the doctor, is more of an authority figure whom grandma is happier to listen to him and abide by his requests than the granddaughter when she's being all
Yes, totally. And I think another benefit there, as somebody noted in the chat here, by saying your doctor wants you to take this and then putting it in her control, right? You're switching the whole narrative there.
Mhm.
So she's making the choice. Something I noticed that happens in the second video, grandma says, okay, I'll do it for him, right? And what she's sort of saying is, I'm not going to do it for you, but I'll do it for him.
And she put a qualifier on that she would do it today for him,
yes,
but maybe not tomorrow.
Yes. And instead of, I think a lot of us, I absolutely put myself in this camp. I would bristle at that a little bit and say, well, you do it for him and not for me, or, oh, great. So we're going to have this fight all over again tomorrow. Right. But instead, the granddaughter in this case just sort of rolled with it. Okay. Right. Fine. We'll only do this today. And then she moved on to the next topic. Let's get out. Let's get outside. It's a beautiful day.
Yep.
Yeah.
And it is respecting that autonomy that grandma wants to retain.
That's right. That's right. So a great example of validating. Let's not fight over whether or not you need to take it.
Right.
Let's find what's important to you. Get at what this resistance really means to you, and address that instead. Great. Thank you. So in brief summary, we want to, when in the face of the brick wall of resistance, do what we can to honor the person's routines, rituals, their personal preferences as much as we can. Consider, are we trying to do this task, whether it's a personal care task or something fun, right, that they're just refusing to do? Is there a better time of day that we might try that? Being flexible, and again, always adjusting our expectations, providing that validation. Okay, sounds fine. If you want to do this for Dr. Brown, but only today, right? Okay. Providing validation, reassurance, and providing as many cues as you can, making your request of the person as positive and action oriented as you can. It's time to take our pills. Let's do it this way. The bath is ready, right? Again, doing what you can to avoid giving opportunities for saying no, or for engaging in negotiation about it. And above all else, right, this most important of the techniques is doing things with the person and resisting your temptation, your impulse to step in and do it to them or to do something for them instead. So all of that was a lot to take in, right? It all may sound like far more than you are capable of. And, just in the same way that it's not safe to swim in the ocean by yourself, it's not really safe. It's not a good idea to be trying to provide assistance to somebody with dementia 24/7 by yourself. You absolutely need support, right? So if you hear these suggestions, you watch the video, you hear what we're saying, but you're thinking to yourself, where will I muster the patience, the ability, the graciousness, right? To take the time to take that deep breath and think it through. This is probably an indication that you need some more support, right? So that's the important topic Jean is going to be talking about in the last segment of the program here today. But before we do that, I want to see if we have any questions we can address.
We do. I have a really good one for you. Someone here has a loved one who is refusing to sleep in bed and prefers to sleep in a chair. This has posed quite a problem because he now has edema in his legs.
Yeah.
He also does not like to use footstools.
Okay. Refusing to sleep in the bed, ends up in a chair. Yeah, boy, this is a tough one. There's a lot of specific, like, person and room and furniture specific questions I might want to ask in order to make a more specific recommendation. But I would try to evaluate, look at all of those reasons for resistance that we talked about before, and see if there's something about the setup of the bed that is making the person uncomfortable. To Jean's important point that she made toward the beginning of the program, resistance isn't always just purely saying no for the sake of saying no. Is there something about getting to the bed that is a challenge for the person? Is there something about the routines of the night? Are you trying to get to bed when the person is already too tired? Is there something you could do to physically get them to the bed before it's actually sleeping time, right? So that there's some kind of a wind down activity that happens there. Is there some physical obstacle to sleeping in the bed? Is it too warm in that room? Is it too cool? Is there, I'm trying to think of any other barriers.
Yeah, my head is going along the same lines as yours. And I'm thinking, like, is it refusing to sleep in the bed at any time of day, like for a nap, as well as at nighttime? Or is a nap okay, but nighttime not? Maybe, some things we've talked about in other webinars is, quality of life things. And what I'm referring to here is it might be things like maybe the sheets are tucked too tight and it feels uncomfortable on his feet. I mean, if he has edema, maybe the sheets are too rough on the edema if the skin is sensitive. I think it's a matter of kind of exploring some of those options. Mm-hmm. And then, what I would suggest that if none of these other things kind of works out is if a family member has a recliner, right, to give it a try and see if it works before purchasing one. Maybe he's more comfortable with a recliner than just with a footstool.
Right. And perhaps, again, this is such a person specific example, but just trying to think about being flexible and adaptive, is there a way you can let him fall asleep in that chair and then, recline it once he's already,
Right.
once he's already gone to sleep, or then make the adjustment and get the feet up under a footstool,
Correct.
something, a way to kind of work around, so you don't have to get his agreement necessarily.
Yeah.
With that, Jean.
Agreed. That's, I think, also good. Get the feet up after he's gone to sleep.
Mhm. Okay. Anything else?
All right. Well, we're going to start winding up a little bit here. So we are going to talk about fairly quickly resources for additional support. And just as we've been talking all along with this whole analogy of the ocean and the waves, don't be swimming alone, folks. That's true for all of us. There's very, very, very few of us that have the kind of extreme skill levels to swim alone. And even some of them succumb to the waves and to Mother Nature. So just approach things that with the idea that you're not going to swim alone. You're not going to do it alone. So get yourself educated as you need, and other friends and family members, so that you can better manage anxiety within yourself in terms of that amygdala firing when your person living with dementia is challenging you and arguing with you and kind of making daily life and daily care more challenging. And for sure to improve your skills. I mean, this area of Alzheimer's disease and dementia and caring for somebody with those diagnoses and learning about it, it's not innate knowledge. It is information that we need to acquire and learn the skills as well too. And you've got lots of resources at hand to help you with that. So identify those community resources and let us help you to identify the community resources that are going to be good for you. So you don't necessarily have to get on your computer and do all this research on your own. Do the shortcut and call Alzheimer's San Diego. We've got lots of information on community resources, the tip sheets that Amy has referred to regarding all the different, bathing and medication management. We've got a lot of information we can share with you folks. Get a break, get some respite for yourself. And if you're not able to get a break or get some respite, one more reason to call us, because we can help you get in contact with and connected with other organizations that do provide respite, other supports that can give you a break. Many of these agencies and resources and supports were shut down during the pandemic, and they are starting to open up now again. So it's a good time to get in touch with some of them and start exploring and get your name on some lists. Find those supports that provide you with that safe atmosphere for coping with daily challenges. In other words, that environment and atmosphere that doesn't set your amygdala firing off. So the place where you can feel calm and safe and secure and supported. And we all need to have some of those places in our lives. So, and if you're having trouble identifying that place, call us, please. And so with regards to that, yes, here we are, Alzheimer's San Diego. And we've got all sorts of different programs and supports to help all of you folks as family members and care partners. And all of them are at no cost to all of you and to the community and the county of San Diego. So there should be no barriers to you reaching out to us. And we've got our experts, our dementia experts and clinical care coaches available on the phones, 8:30 to 5 p.m. Monday through Friday. And that's your first go-to be sure. And from there, we'll direct you to whatever it is you need, whether it may be some virtual support groups, or it might be our virtual Alz Companion program. We have all sorts of online education and training that Amy and I and other staff members additionally provide. And we've got our webinar library, which is really fantastic. And then we've got these other supports of social activities and outings. We've got our volunteer tech team that are available to you even beyond our online education programs. If you're having some challenges trying to set up maybe FaceTime or Zoom happy hours with your family and you need help with that, you can contact us. We'll get a volunteer tech team member to be in touch with you. And we do have some counseling services, and we also have Vitals, which is volunteers who are in touch with folks living alone in the community. And so all sorts of different supports here for you. And we want you to utilize those. So visit our website, which is www.alzsd.org. You can call us, email us, or live chat us. Our general number, and that's the most important number that you need, really the only one you need. And you just call and say you want to speak to a dementia expert or speak to somebody. And it's 858-492-4400. Or fill out a request form, which again, Kristen has sent out to all of you in chat. And you just complete that. And one of our clinical services team members will follow up with you by phone or email at your preference to discuss things in more detail and give you a little bit more personalized service regarding the situation that you are finding that is challenging and you need some help with. So our upcoming online education, we have Living with Memory Loss on June 3rd, and that is presented in partnership with Elder Help, which is another local community resource here in San Diego. We have a drop-in education hour on Tuesday, June 8th, and Amy and I will be there for that education hour. There's no agenda, no topic. It's just kind of like open house. Come on in with whatever your questions are or your thoughts, and we just do kind of free form, and we welcome all of you to participate in that. We have our Date with a Cure coming up on Saturday, June 12th, which Amy will be moderating. I will be there as support, and we are going to have a fantastic panel of local San Diego County, San Diego researchers, and some of them are clinicians as well too, who will be talking about what they are doing with regards to research in the fields of Alzheimer's disease and dementia, and telling us kind of what the latest and greatest is from them, and hopefully sharing some details that are hopeful and promising for all of us to hear. So we invite you to join us for that. And then, of course, lastly, we always just ask you to complete our online survey, which is always very important to us. Your feedback is. You will get a copy of the program materials emailed out to you a little later today. And of course, do reference our webinar library to see recordings of all of the education programs that we do, so that you can revisit them as many times as you need to if you need refreshers, and or if the times we're doing them when we do them live is inconvenient, you can watch at your convenience, whatever time of day you wish. So that's it for us for today. Thank you all for joining us. We hope this has been helpful for you. Please don't hesitate to reach out. Resistance is something we hear a lot about, and between the whole team of us, we've got a lot of different ideas for you. And that's the way to get through resistance is try this, try that, try this, try that. Keep trying, folks, and we'll help you with that, okay? Amy?
Thank you.
Final
Thank
words?
you, Jean. Thank you, Jean. Thank you, Kristen, for being with us here today, handling lots of great questions. Thank you all for asking them and sharing your experiences with us and with each other. And thank you, Perry, for being with us here today and providing support. We're always glad to have you with us. That's a wrap. We look forward to seeing you at future programs, and we thank you for coming.
All right. Happy Wednesday, everybody. Take care.